Good morning, friends. I appreciate everyone's patience. We have a lot of really good content for you, so I'm going to try to keep my opening remarks to a minimum. This is the agenda. We are going to go from 8 to 9:15 with the initial segment. You got 2 breaks scheduled. If you've ever been curious about having a hands-on or face-on experience with CPAP or BiPAP equipment and face masks today, we have got that special treat lined up for you. We have all kinds of demonstratable equipment that you'll be able to get up close and personal with today when we get to that section. We're going to talk compliance and deprescribing, and then we have about a half hour that we've bracketed at the very end of this presentation today to hold for a special question and answer session. So thanks for your patience with that aspect. We spend about a third of our lives asleep. So average it out, you got to figure it's about 25 years that we spend asleep. It's a pretty strange relationship that we have with our consciousness, and most of the time we take that stuff for granted because it just happens automatically. There's something mystical about it in terms of the way we look at our dream state and everything that happens that way, and we take it for granted that it's just going to work, and we wake up and there's no problems. But if your body starts to betray you, and it feels like throughout the course of your nights recharging, you're being repeatedly waterboarded, and your breathing is interrupted, that's not conducive to good health, especially when that happening time and time again starts to impact you with saying, hello, here's a bunch of other new chronic diseases that are now being added to the mix thanks to this malady. So how do we get back to having a good relationship with sleep? How do we make sure that we're balanced as an organism, and this thing is a good thing for us, not a bad thing? We have a panel of phenomenal experts today who are going to help answer those questions for you and help point the way, because there's a lot more attention being focused on this disease state than there has been in the past. To begin things today, we are incredibly fortunate to have one of the most preeminent local experts on sleep from the Oregon Clinic, Dr. Bill Bowerfind, here. He's Critical Care and Sleep Division Medical Director, Providence Portland Medical Center, Sleep Disorders Center, and Providence Milwaukee Sleep Lab from the Oregon Clinic. I'm going to shut up now and pass the mic over to him so he can take the rest of the way here and get us started. So please give a warm welcome to Dr. Bill Bowerfind.
Oh, that was the best introduction I've ever had. I'm a preeminent sleep specialist. That's excellent. All right. So thank you for that. That was a great introduction about also about the reasons that we are concerned about sleep apnea and sleep in particular. And then this is a little bit of an outline of what we hope to get through here. Talking about the scope of the problem, we'll talk a little bit about benefits of treatment and how it affects other disease processes. Some definitions about what sleep apnea is. It's a little bit more than just sleep apnea. There's central sleep apnea and some other types of sleep disorder breathing. We won't dive too much into that. And then a little bit about how to identify patients at risk, a little bit about treatment, and then we may touch on some about follow-up. And some of this is going to be an appeal to you all, to the primary providers and caregivers, because we heard that that sleep apnea can affect a third of our lives. It affects nearly a third of our patients. It actually has a prevalence on par with hypertension and diabetes, and the population is growing, both literally in individuals in size, which with the obesity epidemic, which predisposes people more to sleep apnea. But the number of patients, as we will discuss, that are coming to light with obstructive sleep apnea is growing. The estimates are that 85% of these patients are undiagnosed right now. So we're kind of experiencing the tip of the iceberg. And there just aren't enough sleep specialists and specialized providers to take care of these folks in the long term. So I wanted to just start off waking everybody up with a little bit of audience participation here, okay? So I'm going to ask you all to raise your hands and vote here. So Since we're all getting started with our caffeine this morning, I had a question for you about which has more caffeine. Okay, so here are a couple of common ways that we take in our caffeine. We've got, and the sizes of the drinks there, the Monster Energy, Mountain Dew, Red Bull. The Starbucks on the end there is an 8-ounce Starbucks, by the way. You can't order that. That's not on the menu. But anyway, I want a show of hands to see how many people think Monster Energy of these different types of caffeine has the most caffeine in it. Anybody? Anybody voting for Monster? You have to vote once. Mountain Dew. All right, we've got a pretty smart audience here. Red Bull. And what about Starbucks? All right. So it turns out that Mountain Dew actually has the least amount of caffeine at 54 milligrams. And this is the milligrams per ounce are there as well. Okay, so 4.5 milligrams per ounce. Keep in mind that the recommended dose of caffeine is about 200 milligrams. We're talking about this because a lot of your patients with sleep apnea are sleepy, and they're doing a lot of this stuff to keep awake. Red Bull, 9.5 milligrams per ounce. Monster Energy, 10 milligrams. Starbucks has 180 milligrams. Remember, 200 milligrams is a recommended limit for an individual, just in the 8-ounce Starbucks. So with your first couple of sips here today, you're probably close to that limit. These are probably 12-ounce cups. But the thing I want to point out here is that we're all taking in a lot of caffeine to deal with sleep deprivation. And people with obstructive sleep apnea are sleep deprived. They may tell you they sleep 8 to 10 hours, and they think they sleep well, but their sleep is very fragmented, and a lot of them are then trying to keep awake by downing the caffeine. Stimulating effects of caffeine within 15 minutes. The half-life of caffeine, importantly, is about 6 hours. So a lot of your patients who are having soda, drinking that Mountain Dew with dinner are actually fragmenting their sleep even more than it's already being disrupted by the obstructive sleep apnea. And then caffeine withdrawal occurs in about 12 to 24 hours of discontinuation. It turns out that all of you are drinking caffeine today not for the benefits of caffeine. Caffeine actually is recognized by the NCAA and by the Olympic Committee as a performance enhancer. None of you are getting any of those benefits because you're chronically using it. You're just treating your withdrawal. You're just warding off headaches. You're not really getting a lot of stimulation from it. Yeah, so when I talked about Starbucks, that Starbucks is notorious for the amount of caffeine, and so it depends on your type of coffee and how you brew it. Tea, similarly, there's a range of different types of caffeine and how you brew it. But the important thing that I wanted to point out is that when you ask your patients about caffeine, it's actually important to ask what's the source, because it can have a big effect. All right, back to the problem at hand. So obstructive sleep apnea, these are estimates from 2016. There's actually some recent data that I saw yesterday suggesting that these numbers are actually low. But looking at the US population of close to 250 million people, the prevalence of obstructive sleep apnea is estimated to be anywhere, depending on how you define it, between 12 and 20% of the population, meaning that we have somewhere around 23, 24, 25 million undiagnosed patients with obstructive sleep apnea. And you can see that if those patients that are diagnosed is just 6 million, and of those, about 5 million currently are on CPAP. That's the most common treatment for obstructive sleep apnea. So 85% of people diagnosed end up being treated with CPAP. But again, that 5 million represents only 20% of the population at this point. So those numbers are going to continue to grow. And then when a patient starts on CPAP, they're on it for, hopefully the rest of their life if they don't seek some other remedy for their weight issue or their obstructive airways. So that comes out to be somewhere around 250,000 CPAP users in the Portland metro area once those folks are all diagnosed. And so going forward, once they're diagnosed and treated, we're supposed to be seeing those folks back annually to make sure they're still using their devices. So that ends up being 250,000 follow-up appointments a year, filling up all the slots in our clinic for your patients that still need to be diagnosed and treated with other problems. So this issue is where we need the help with the follow-up going forward, is that if we're going to continue to diagnose and get people started on treatment, we really need some help on the back end. And really, that's where the benefits are. We talk a lot about diagnosis up front and the cost of all that, but the long-term benefits both to health and the long-term cost savings are in the long-term treatment and maintenance of these patients once we've done that upfront diagnosis. This talks about the costs of what happens with the undiagnosed population here. So on the left, where 80% of OSA patients are undiagnosed, we have $120 billion of non-healthcare costs over here in the left-hand panel. Over here. The patients who are diagnosed, they don't have the same amount of non-healthcare associated costs. So those are all the postoperative complications, the ways that sleep apnea affect other health problems like diabetes and high blood pressure. We'll touch on that a little bit. But over here in the future, where we hope that no patients are undiagnosed, it turns out that there's a tremendous cost savings to getting these people treated and maintained on therapy. While it seems like a daunting and cost prohibitive thing to get people a sleep study of some type, get them a machine and so forth, I want you to understand that long term, the cost savings are tremendous. So this is just getting back to the number of patients. Portland, we have a problem here. 12% of the CareOregon population has obstructive sleep apnea, and maybe even higher in higher risk populations. It turns out that sleep apnea is even higher in other complicated sleep disorders like central sleep apnea from chronic narcotics and other drug use. So we need your help. Your patients need your help. The benefits of treatment. So this is talking about the effects of obstructive sleep apnea on a lot of different disorders that you all are commonly treating. So hypertension, after 1 year, patients surveyed said 41% report blood pressure improvements. That's been documented in numerous studies about the cardiovascular benefits of treating sleep apnea and the cardiovascular risk of untreated sleep apnea. So patients who have had a heart attack, if you look at folks with obstructive sleep apnea and you treat them, they are half as likely to have another heart attack. Same with stroke. Diabetes, improvements in hemoglobin A1C. It turns out there's a lot of hormonal regulation that takes place during those 8 hours of sleep that gets disrupted when your sleep is fragmented, and that affects all of your hormonal regulation, but diabetes is chief among those. Asthma as well. There are documented improvements in forced vital capacity and in spirometry, as well as improvements in long-term maintenance. Insomnia. A lot of patients have insomnia that goes along with obstructive sleep apnea. And so there's a tremendous improvement in sleep quality. Same thing for depression and again for heart disease here. So, and these are just a couple of examples of other major diseases that you all are treating that are comorbid with obstructive sleep apnea. And if you treat the sleep apnea, you see a lot of these things go away. I've had, just yesterday, actually, I saw a patient who came to me previously on 3 anti-anxiety medications, treated them for their obstructive sleep apnea. They are now off of all of those medications because they were having a lot of sympathetic surges at night that carried over during the day, and the quality of their life has improved dramatically. There's, numerous stories like that. Quality of sleep across comorbidities. So this is just looking at patients' reported quality of sleep with different diagnoses. So patients with diabetes, high blood pressure, depression, and so forth. After treatment, it improves not only, like the last slide showed, it improves not only those disease states, but it also, patients come back saying, and the other benefit is that I'm sleeping better. So here we see very bad. This is sort of the key down here, going from very bad over here to very good in these colors. This is a terrible slide for me because I'm colorblind, but hopefully this point comes across to you all. that before treatment, most of these patients are reporting high percentages of very bad or bad sleep. And then after treatment, we're seeing that their sleep quality is improving across all of these diseases. This is sort of a graph looking at oxygen saturations that are occurring across a night. This is in the first part of the night with a patient with severe obstructive sleep apnea. Here you can see their oxygen saturations are plummeting. If you stretch this graph out, what you see is that this is actually a sort of a sawtooth. What we see is these respiratory events happening and a drop in oxygen saturation, and then when they are having recovery breaths after they open up their airway again, their oxygen saturations come back up to normal. And so this is a patient with severe obstructive sleep apnea, and I can tell you that they're probably either on their back or in REM sleep during these deep depressions. Here at A, this is a continuation of that night. They're put on CPAP, airways opened up, and you can see the dramatic changes there. So imagine, you know, spending the last 20 years of your life, a third of your life with oxygen saturations dropping down here to 60%. That's not good for your body and for your brain. This is looking, this graph here, there's a couple of different examples here. So first we're going to look at the bottom here. This is actually looking at sympathetic nerve activity in a patient with obstructive sleep apnea. I told you about high blood pressure. This is an example of what's happening. This is respiration here. So here's a breath, and then there's an apnea here, and then there's a couple recovery breaths and an apnea. And what we're seeing here is that during those apneas, the blood pressure is sort of down in the normal range, and then as the apnea continues here, blood pressure is rising, then the recovery breaths, and the blood pressure goes back down again. Sympathetic nerve activity is going crazy during the apnea. This is looking at that same patient while awake, steady blood pressure, steady breathing, steady sympathetic nerve activity. And then this is the patient on CPAP while in REM sleep. And we can see here the blood pressure staying even, the respirations are present throughout the entire time, and that sympathetic nerve activity is much decreased. So if you've got this going on all night, every night, and in some cases more than 60 to 100 times an hour, this is the sympathetic nerve activity. This is sort of that fight or flight going on in this patient all night long. These sympathetic surges that are just going on continuously. It's exhausting. And long term, those elevations in blood pressure carry over. This is very, very stressful on the body, on the mind, on the heart. So patient perspective of treatment, respondents gained an additional 2 hours of sleep after they started using CPAP, 11 times increase in good or very good sleep. Quality of life was very good. That score tripled. Productive work time grew, and work absences declined by 40% once patients were treated. So the benefits of what we call the triple aim, this is looking at why treatment is better for everybody involved in the care. So patients, improves the health and life expectancy, increases productivity, improves quality of life. Providers, aligns with the population health incentives, improved outcomes, and lowers healthcare utilization and reduces admissions and readmissions. And then payers, it reduces long-term cost, increases productivity, and lowers, importantly, accidents and workplace problems. We didn't talk about that, but the cost of obstructive sleep apnea on the workplace is tremendous. Some definitions. So this is what we're talking about. When we talk about obstructive sleep apnea, you may hear the term apnea-hypopnea index. Okay, so apnea, this is a normal airway here with the soft palate and the uvula here in the base of the tongue. A hypopnea, you can think of these things as being on a spectrum. So it goes sort of from snoring to what we call hypopnea. I always say that's a fancy word for shallow breathing. By our definitions, hypopnea includes a 4% oxygen desaturation. Not important to remember that number, but what I want you to remember is that the narrowing of the airway back here with shallow breathing that has a physiologic consequence. So you all can breathe deeply and shallowly. That's normal while you're awake. It's also normal while you're asleep. But if we see the oxygen saturation dropping, we say, okay, that has crossed the line. That is no longer normal breathing. That is now having a physiologic consequence of a drop in oxygen. We call that a hypopnea. These respiratory events have to last for at least 10 seconds. So 10 seconds of shallow breathing with a drop in oxygen, or 10 seconds of no breathing. And an obstructive apnea we see as a patient who's not breathing, but the bellows are still working. They're trying to breathe. So in a sleep study, we'll see the chest and the abdomen are rising and falling. They're trying to breathe, but there's no airflow. And that constitutes an obstructive apnea. So here's sort of a summary of what I just went through. Apnea, no airflow for at least 10 seconds, but continued effort. Hypopnea, that 4% decline with shallow breathing. Central apnea, by comparison, and we see this in a lot of patients with narcotics, on methadone, on buprenorphine or Suboxone, other chronic narcotics. Different from obstructive sleep apnea. Here we just see the patient not breathing, so no airflow, and no effort. So they're just sort of laying there, not doing anything, heart's beating, but no airflow, no effort. And then complex sleep apnea. I'm just throwing these terms out there because these are things that you may hear about and begin to familiarize yourself with. So complex sleep apnea, sometimes we see people with obstructive sleep apnea, we put CPAP on them, and they convert over to central apneas. This becomes a little bit more complicated to treat, but is very treatable. So obstructive sleep apnea that becomes central during treatment. And then another crazy thing, and I apologize for all these terms, I hate them, but upper airway resistance syndrome. This is a patient that doesn't have apneas, they don't have hypopneas, but I explain this to patients like if you've ever seen your uncle sitting there in the recliner and they're drifting off to sleep, and then you see their face and they're snoring and they're kind of go, and you see like they're snoring, something's going on, they look like they're waking up. They didn't stop breathing, and if we tested them, they didn't have a drop in oxygen saturation, but that snoring is causing disruptions to their sleep. And that's upper airway resistance syndrome. Unfortunately, a lot of insurance, that can fragment sleep and cause the patient to feel horrible. A lot of insurances don't recognize that. And part of this is just sort of the evolution of obstructive sleep apnea and the science of it. We haven't caught up with that. This is a significant problem, this upper airway resistance syndrome, for a lot of patients. And we make the diagnosis, and I think it's pertinent to the patient's health and the reasons why they're presenting with symptoms. But insurance companies say, no, we don't recognize that. You can't treat that. It's frustrating. Hopefully we'll catch up with that one day. And then this is just a graphic representation of what these things look like. Again, central apnea. This is looking at effort of the chest and abdomen. We measure this with bands on the chest and abdomen that expand and send a signal to the machine showing the respiratory effort and the airflow here. So central sleep apnea, nothing's going on. Obstructive sleep apnea, no airflow, but we're seeing effort in the chest and abdomen. And then again, the oxygen desaturations that are occurring with these events. And then I wanted to just go over the definitions here because this talks about the severity of sleep apnea. So during a sleep study, we count all these things that happen on an hourly basis, and we divide them into the amount of time the patient sleeps, and we come up with a number of respiratory events per hour. So it's actually normal to have up to 5 events per hour of these obstructive apneas or hypopneas. If you have 5 to 15 of those events per hour, that's considered mild. And per Medicare criteria, if that patient comes in and doesn't have any symptoms, and sometimes that's like this, the spouse made the husband come in. He's like, I don't have any symptoms. I don't have any comorbidities. My wife just hates my snoring. So we treat, or we diagnose that patient. They've got mild sleep apnea. The question is, does that patient need treatment? And if they don't have symptoms or comorbidities, they might not. But if they come in with problems, they've got other comorbidities, high blood pressure, diabetes, stroke, then we would treat even the mild patient. Moderate is 15 to 30, and severe is greater than 30. And a lot of times, this is severe. We see patients with AHIs of 120. So where they're having, 2 events per minute of these, and just as their, oxygen saturations are recovering, they dive back into another event. And they're just strung out, as you can imagine. And then the respiratory disturbance index, this is where we count those RARAs. We call those respiratory disturbances, where the snoring is causing an arousal. It's important that you can't diagnose this on a home sleep test. You have to have an EEG, because you got to see the arousal, the fact that this snoring event is actually disrupting their brainwave activity. So a lot of these patients go undiagnosed from home sleep tests. So now we're going to talk about identifying patients at risk. So patients at high risk for obstructive sleep apnea. So, okay, we get it. This is a significant disorder. How do we know who to go after, and when should we be thinking of this? So importantly, obstructive sleep apnea increases linearly just about with BMI. So as BMI increases, if you're seeing patients, certainly someone with a BMI over 35, I would be thinking, do I need to ask those questions about obstructive sleep apnea? And then significant comorbidities. So congestive heart failure, atrial fibrillation, refractory high blood pressure. What do I mean by refractory? If you're starting to add a second antihypertensive, at least be thinking, I wonder if this patient might have obstructive sleep apnea contributing to this. And oftentimes, if we treat them, they can come down off their medication, maybe get rid of one of those medications or require less medication. Type 2 diabetes, huge overlap between obstructive sleep apnea and type 2 diabetes. And if you're starting to see, type 2 diabetes and hypertension, that's a patient that I would be thinking, okay, do you snore? Anybody tell you stop breathing? Arrhythmias, patients with atrial fibrillation. If you have a patient with atrial fibrillation, divide them up into two groups. They have obstructive sleep apnea. Treat one group, don't treat the other. You are twice as likely to stay in normal sinus rhythm if we treat your sleep apnea compared to if we don't. So, and we think that those sympathetic surges and so forth contribute to the development of atrial fibrillation as well. But once the patient has it, if you treat their sleep apnea, it can help with the management. Stroke. Early on, up to 70% of patients after a stroke will have sleep disordered breathing. The majority of those will have obstructive sleep apnea, but about 30% of those will also have central sleep apnea. Pulmonary hypertension, high-risk driving population. So a lot of folks that drive for a living, more and more Uber drivers or things like that, but they don't have to get tested the way that a lot of commercial truck drivers do. Unfortunately, a lot of commercial truck drivers now know that they shouldn't check off that box that says, do you snore? Because if they check that off, they get into our office and they've got to go through the evaluation. So a lot of them are savvy about this now, but you really got to question those folks. And then bariatric surgery candidates. It's actually a requirement that patients get screened before bariatric surgery because the perioperative risk is tremendous. Clues to the diagnosis, patients who snore have witnessed apneas, gasping and choking at night, non-refreshing sleep, a lot of morning headaches from that chronic low oxygen overnight and those sympathetic surges. In men, we see a lot of nocturia. One of the things that men come back most excited about after treatment is, they'll tell you beforehand, I get up 5 times a night to pee. They come back and they're sleeping better. Their spouse is saying they don't snore anymore, but they're delighted that they're only getting up maybe once a night to pee now after treatment of the sleep apnea. A lot of that is because they're not awakening. So a lot of patients wake up from their sleep apnea and they kind of do a self-assessment. I wonder why I woke up. My bladder feels a little full. So they get up and they pee a lot more. They have a lot more awakenings. Decreased concentration, memory loss, decreased libido and irritability. Exam clues, so again, the increased BMI. Retrognathia, that is the patients who have a recessed jaw. A clue to this will be a lot of, in men, a lot of them will have goatees. A lot of men will use goatees to sort of disguise a prominent jaw. There's nothing I can do about having a recessed jaw. I can't do anything to de-emphasize my jaw, but retrognathia, because the jaw is pushing back, their posterior airway will be narrowed in a lot of these folks. High Mallampati score, I'll show you what that means in just a second. Increased neck circumference, so in men, neck of 16 inches or larger is increased risk for obstructive sleep apnea. And then cor pulmonale, so patients who have lower extremity edema and other signs of cor pulmonale. Mallampati score, this is where you ask the patient, you don't want them to say ah, you just want them to open up their mouth, stick out their tongue in a relaxed fashion, and then see whether you can see into their throat. If you can see the whole airway, that's a normal airway. If you can only see the soft palate, you can't see any of the uvula or very little of the soft palate, that's a very high-risk airway right there. The Mallampati score evolved in the surgical literature by anesthesiologists looking at airways. It actually is used more to predict difficult intubation, but the Mallampati score does track with the severity of obstructive sleep apnea as well. So just looking in the patient's mouth, and again, this might be just something part of your routine where you're doing this stuff, you look in their mouth, you might be looking for thrush or tonsils or whatever, but now when you're looking in there and you can't see back there, you got a pretty crowded airway. And this is another thing, is this tongue scalloping. Once you start looking at this or you know what it is, you'll start seeing it all the time. But this is, these indentations on the tongue are actually from the teeth, from the tongue being large for the airway. And that'll give you an idea that there's a disproportion there, that this patient might have a crowded airway. And so when you start looking at these things and having the patients open their mouth, you start making, these associations. And, sometimes I'll be seeing patients for other things and I'll see their airway, and then, I'm seeing them for asthma, and this is what prompts me to ask those other questions. This is 2 questionnaires that we use, and I would like you all to become familiar with these questionnaires, because as you're referring patients to us for obstructive sleep apnea, we really appreciate getting some of this history. So if you're referring a patient and you think that they might have obstructive sleep apnea, to help us screen the patient and figure out how to take care of them, we need some information from you all. So what we are looking for is some sort of documentation saying, I think this patient has sleep apnea. So I think they snore, they have witnessed apneas, they have symptoms. And then also if they have a manifestation of sleepiness, so excessive daytime sleepiness. So not only do they snore, but it's affecting their life. Okay, they have a symptom and it's affecting their function. So this is called the Stop Bang questionnaire. Stop Bang is the acronym that we use to remember this. So S is for snoring. Do they snore? Yes or no. Are they tired? Yes or no. Do they have observed apneas? Yes or no. High blood pressure. BMI greater than 35. Neck circumference. Age greater than 50. Neck circumference greater than 40 centimeters or 16 inches. And then gender, are they male? High risk for sleep apnea is a score of 3 or greater. Okay, it takes nothing to get there, right? So a 50-year-old male who's got a BMI of 36 and high blood pressure. That's every 50-year-old male probably you see. And then you tack on a couple of other of these other things, but it doesn't take much to get to a pretty high risk for obstructive sleep apnea. Pretty simple questionnaire that can be, a lot of these things are obtained just on the vital signs. There's very little that you need to do beyond the usual, admission of the patient and checking their vitals to get this. Neck circumference, if you've already got some of these other things, you don't even need to check the neck circumference, and a lot of times you can just eyeball it. If they got a huge neck, boom, you're there. So, yeah, it just turns out that sleep apnea is more prevalent in males. Yep. And then the other thing is a symptom score here. So this is called the Epworth Sleepiness Scale score. And this is just a number of questions. We hand this questionnaire out to patients on each visit, and they score their chance of dozing from 0 to 3. Never doze versus a high chance of dozing or in between. When you're sitting and reading, watching television, sitting inactive, and so forth. A big one to pay attention to is in a car while stopped for a few minutes in traffic. So if they're putting a 3 there, you know, maybe their overall score isn't great, but if you see that one, that's a big deal, right? And I'll mention this right now just because I'm thinking of it, but and I want to make this point that, you know, you see your patients for a lot of different diseases. This is one of the only diseases that your patients will have that could kill you when you're driving, you know, on the road with these folks. So, you know, there's a lot of things we treat patients for, and we tell them, well, we got to treat your high blood pressure and so forth, and, you know, we're going to start you on these medications, and they come back and they don't really feel any better with their high blood pressure treated, but we reassure them that, oh, this is great for you. But, you know, treating this, patients are going to feel better, and you're going to be less likely to die. So, you know, there's a lot of advantages of treating this disorder. So the stop bang and the Epworth Sleepiness Scale score, these are things that eventually we would like you all to be handing out to your patients or filling out as part of the referral process. I know it's one more thing, but if you can just get them to fill this out on their own, you know, after you see them, have the medical assistant or someone get them the Epworth score and fill out the stop bang, that would be awesome.
If they sleep on their side, are they still?
Yeah, so the question was about, you know, whether they have symptoms on their back and their side. Yeah, so, you know, the next question is how do they think they usually sleep? And it's a tricky question because most patients have sleep apnea that is worse when they're on their back. Absolutely, good point. And sometimes we see such a disparity that we can treat them with positional therapy. We actually, and we'll touch on that, we have them wear devices to keep them from rolling onto their back. And you'll have patients that say, I never sleep on my back, okay? I hear that all the time. And then we put them in the sleep lab and they spend 70% of the night on their back. And then I say, you know, did you sleep on your back during the study? No, didn't sleep on my back. They don't know once they go to sleep. They don't fall asleep on their back, but they roll over onto their back and then they have horrendous problems. And then, so the answers to those questions only get you so far. And that's one of the things about this whole process is that asking all these questions is great and doing all this screening, but there's only really one way to know, do you have sleep apnea or not? And I'll comment further by saying there's a spectrum there because we see patients sometimes who come in and they meet all the stop bang. And I'm like, you have horrible sleep apnea. And then we treat it, or we put them in the sleep lab and miraculously they don't. And then I also see, you know, somebody who comes in, a thin young female who, you know, says, boy, my partner says I snore a lot and they think I have sleep apnea. And I'm like, you don't have sleep apnea, but you know what? Here you are in my office and I now you're in a specialist office. I guess I ought to screen you. And they've got horrendous sleep apnea. So, you know, we do a lot about trying to assess who's high risk, who's not. But I'll tell you, you got to do the study to figure it out. So that takes us to establishing the diagnosis. Several different types of studies, and this gets a little confusing, but bear with me and we'll get through it. So the split night polysomnogram is the sort of the gold standard on how to assess patients for sleep apnea. Split night means that during the first half of the night, we assess whether they have sleep apnea, and if they have significant sleep apnea, meaning an AHI of about 20 or greater, and there seems to be enough time left in the study, we can actually put CPAP mask on them and increase the pressure in that, watch their breathing, and hopefully by the end of the night have a diagnosis and also know how to treat them. And that takes place in the sleep lab. We'll talk a little bit more about that. Home sleep testing, there are a couple different types. We're going to touch on those, done in the patient's home. And then there are the ways that we also can assess what's the best treatment if we go the CPAP route with PAP titration or auto-titrating PAP. Pre-study considerations, If you all are seeing patients, or patients may ask you or get worried about their sleep study, for whatever reason, we say, well, we're gonna do a sleep study on you. Patients get nervous about that. They're like, oh, I got to sleep in the sleep lab. I'm never gonna sleep. I better take a nap. I better sleep in before I go and get the sleep study. We want patients to hopefully come and be sleepy and ready to sleep. So we discourage napping, discourage caffeine prior to the study. What about alcohol? Ideally, alcohol will make sleep apnea worse. Definitely. It makes snoring worse. My question to patients is, when I'm talking to them about that, if they chronically use alcohol and then they come into the sleep lab and they think, oh, I'm going for a test, I'm not going to have any alcohol, and then we study them and they don't have any sleep apnea or it's very mild, but then, the next 364 days of that year, they're going to drink alcohol, they may have sleep apnea, and we just studied them under their normal situation. So I have that discussion with patients. Well, if you always drink and you're not planning on stopping, now, we've talked about stopping for the last 6 visits, but you haven't done it. So I'm guessing you're going to keep drinking. Let's have you go ahead and have a couple of beers, have someone else drive you in and get studied. That question comes up a lot. So the key point there is we want to study you under your normal conditions, because otherwise, we're not learning what you do on a normal night. This is the sleep lab at the Oregon Clinic. So a lot of patients have this preconceived notion of what the sleep lab looks like. It's fun to ask them, so what do you think that's going to look like? We've got sleep number beds. It's very comfortable. There are no windows. It's a sleep conducive environment. This is what patients imagine, though, when they're thinking about the sleep lab, right? So, they've got the crazy sleep tech standing there monitoring them, and they're strapped down on the bed, and all these electrodes and things beeping and buzzing in the room. So it's good to demystify that a little bit for patients. But having said that, this actually is one of our ICU nurses. He does look a little like Frankenstein in this picture with all this stuff on. So this is a split night polysomnogram. And again, the gold standard test. Diagnostic followed by the CPAP titration if criteria met. 16 channel attended study, so there are 16 different wires and bits of information that we get from this. So we have the EEG monitoring. We have a cannula under the nose to monitor airflow. We have electrodes on either side of the eye to look for rapid eye movement sleep. Electrodes under the chin to monitor muscular tone of the upper airway. Bands, as we talked about earlier, to measure chest and abdomen effort. A probe on the finger to measure oxygen saturation, and electrodes to monitor the heart rhythm, and then electrodes on the legs to monitor for limb movements. Patients are also videoed. So patients with parasomnias or unusual activities with other sleep disorders, and also to monitor sort of body position, they are being videoed during it. And the sleep is scored. Another key advantage to the sleep, to the split night study, there's a tech there watching them. So you learn all sorts of stuff about patients when the techs are able to monitor stuff. Real quick anecdote, we had a patient who was being studied for insomnia. Couldn't figure out why the patient had insomnia. The patient shows up with a cooler, this is true, takes 6 cans of Pepsi out, opens all 6 cans on the bedside, says, oh, I get a dry mouth during the night, and she sips on the Pepsi all night long and has horrible insomnia. And it was figured out, embarrassingly by getting the sleep study. But anyway, you see a lot of patient behavior that is key to their diagnosis. Disadvantages, it's in the lab, so, and patients worry that they're not going to sleep in a different environment. And then the cost. It is more expensive than a home sleep test. This is just an example of some of the information we get from a home sleep test. We have the EEG activity up here that is measuring sleep staging and measuring arousals. We have eye movements here that tell us when patients are in rapid eye movement sleep. This patient is in REM sleep here. And then the muscle tone, the EKG. Here's the respiratory efforts and the oxygen saturation. Here's the patient having an obstructive apnea, no breathing, but the respiratory effort is there. And here's that same patient, again during REM sleep, with nice flow on CPAP, no oxygen desaturations, no EEG arousals. Home sleep testing. I took the sleep out because it's actually a home apnea test. We don't monitor sleep with the normal type 3 sleep study. Patients don't have the electrodes on. The patient comes in, they learn how to put the sensors on. The sole indication for a home sleep test is ruling out obstructive sleep apnea. Excuse me, I should say ruling in obstructive sleep apnea, and I'll get to that distinction in just a second. If a home sleep test, it says here, attended full sleep study is mandatory if a home sleep study is non-diagnostic. The reason for that is that home sleep testing can miss clinically significant sleep apnea. So we always say it's good for ruling sleep apnea in, it's not good for ruling it out. So if you think that this patient's high risk, you send them for a home sleep test and it's negative, you probably ought to go on and do the next study to make sure that they really don't have it. And I'll touch on that a little bit more in just a second. Other uses, for some patients, either they refuse to come into the lab or they've got, they have caregiver responsibilities at home, they've got children, there's reasons that they can't come into the lab, and we don't want to just ignore those folks. So, it may not be the optimal test for some people, but it's better than nothing. The other disadvantage is that you can't do the split night on them. It's for diagnosis only. This is an exhaustive list of HST exclusion criteria. You guys will have a list of HST exclusion criteria that is not as exhaustive as this. I just want to touch on a couple of things here. Patients with an extremely high, so first of all, at the top here we have the Epworth and the stop bank. So this just says patients who are at low risk. Home sleep testing is really indicated for patients who have a high pretest probability for obstructive sleep apnea. If you're kind of on the fence, if it's that thin lady that I spoke about earlier, I would probably opt to get an in-lab study on that patient, because I'm thinking if they have sleep apnea, it's going to be pretty mild and we'll probably miss it on a home sleep test. Other things, so severe or significant congestive heart failure, oxygen-dependent lung diseases, COPD that's oxygen-dependent or severe should not be getting a home sleep test. BMI greater than 50 is an exclusion criteria, so the significantly morbidly obese. Cognitive impairment, patients who are going to have uncertainty about when they get home how to use the device. Neuromuscular diseases, these patients should not be getting a home sleep test. And then another really important one is insomnia. Again, we don't track sleep as well with a home sleep test. So if patients have severe insomnia and they may not be sleeping for a significant proportion of the study, we don't want to get a home sleep test on them. And I'll touch on that more in just one second. We kind of went over most of this stuff. This is what a home sleep test looks like, less obtrusive. They do have a cannula under the nose. They've got a device here that's measuring respiratory effort and body position. And then on the finger here, oxygen saturations and heart rate. So less costly, less interference with sleep. Maybe patients get to sleep in their own home environment. It's diagnostic only. It's not attended. Can't detect those upper airway resistance syndrome because we're not seeing the arousals on the brain waves. And there's a significant failure rate. Patients will go home, misapply the leads, think they started the device, they didn't, and so forth. This just gets at the limitations of some of the home sleep testing devices, and this is what I was talking about earlier with insomnia. In a diagnostic sleep study, a split night in the lab, we take the respiratory events and divide by the total sleep time. So we know when the patient's awake, we know when they're asleep, we know how many respiratory events they have, and we can tell you exactly what their AHI is. On a home sleep test, we divide by the recording time. So the patient may have the recording on for 12 hours but only sleep 6 hours, and we're going to underestimate the severity of the sleep apnea by half in that instance. This is an example of a patient who was asleep for a short period of time, had a ton of events, and then lied there awake for the remainder of the time. And when you average it out, it ends up they have no significant sleep apnea overall, but actually when they were asleep, they sure did. We just didn't know when they were asleep. So poor choice for patients with insomnia. The WatchPat device is a little bit of a revolutionary device that has come to prevalence in the last couple of years. This is a pretty slick little device that monitors sleep through peripheral arterial tonometry, okay? And if you never heard of that, or that sounds kind of weird, it kind of is. And what this does is it monitors the peripheral arterial tone of the blood vessels in the finger. There's this thing on the finger that blows up around the finger, and it measures the tone of the vasculature. Turns out that that sympathetic activity I showed you on the earlier slide during this talk, sympathetic activity correlates with respiratory events. And they found out that measuring that tone in the finger and correlating that with changes in the blood pressure, changes in the oxygen saturation, they actually can do a pretty good job of figuring out when respiratory events are happening, and also a little bit about sleep stage scoring. So while this device looks less intrusive even than the home sleep test that I showed you earlier, it does do a little bit of sleep stage scoring. It's not as precise by any means as a split night, but it does give you a little bit more of an idea of whether the patient's asleep or not. So it measures these things. It does measure sleep and respiratory events to some extent. Limitations of this: if patients are on alpha blockers, okay, so prazosin, things like that, that affects the peripheral artery, and those patients cannot be studied. If they have arrhythmia, this needs to have normal sinus rhythm. So if patients have atrial fibrillation, not a candidate for this either. And there's a question as to whether patients with significant diabetic neuropathy would be appropriate for this. Easy instructions for the patient, less interruption of sleep. Also chain of custody. So this is great because if you have a truck driver and you're getting a home sleep test on them, unfortunately, there are a lot of these folks who know that if I've got sleep apnea, I'm going to be taken off the road. So they take their device home, they dutifully put it on their spouse, and then bring it back the next day, hoping that their spouse doesn't have obstructive sleep apnea. And then, so this actually requires, when they come in for this, we put it's like a FAIR bracelet. We put that on them, and the device has to be clicked into that so that you know that that's the patient that you're studying at night. Because once that device leaves your office, you don't know who's getting the study. But with this, you do. WatchPat, not for everybody. We talked about there are those inappropriate folks, significant congestive heart failure, things that affect the vascular tone. We do a lot of this screening. This is not necessarily stuff that you need to be focusing on a lot, but things may change over time in terms of the referral patterns and how we're dealing with these patients and getting them in for their studies. So we may be asking you all to think a little bit more as you're referring patients about, whether or not they're candidates for these different types of assessment. Avoid, again, alpha blockers, permanent pacemaker, sustained arrhythmia, peripheral vascular disease. Again, home sleep tests, high pretest likelihood of sleep apnea, no contraindications, good for ruling sleep apnea in, but doesn't rule it out. A negative study does not mean they don't have sleep apnea. A negative study does not mean they don't have sleep apnea. So, and a negative study should be followed by an in-lab sleep study. And that's a good thing to warn patients about. Okay, we'll start with the home sleep test, but just so you know, if that's negative, I'm worried that you have sleep apnea. So if that says you don't have it, we may need to go on and do the next study. Treatment options, CPAP is the gold standard. CPAP, we say when in doubt, pressurize the snout. it is going to treat the vast majority of patients. Now, whether those patients are going to be able to tolerate it is a different thing. We can talk more about that with the examples over here. Other types of treatment, obviously weight loss. We always talk to the patients about weight loss. For patients, I get an hour for a new consult for sleep patients. If I think they have really bad sleep apnea, pretty quick, I'm saying you need a sleep study. But now let's talk about why you need the sleep study. Let's talk about the underlying problem, because I can put a mask on your face and feel like I did my job, but you're still going to suffer the ravages of all the other things associated with your obesity. We try to be helpful with that. For patients with mild or moderate sleep apnea, oral appliances are an option. These are examples of some oral appliances. What these do is advance the lower jaw, pulling the tongue away from the back of the throat, and can be helpful for patients, again, with mild or moderate sleep apnea. For patients with severe sleep apnea, these are usually not adequate. And then also for certain patients, patients can have a variety of presentations with their sleep apnea, as we talked about with the positional situation, or with different stages of sleep. So you might have a patient who, on their study, it says they have mild sleep apnea, but when they were on their back in REM sleep, that's when all the action happened. They had horrendous sleep apnea during the 5 minutes of REM sleep on their back. That patient, even though they had mild sleep apnea, we might say not a good candidate for an oral appliance, because they don't really need anything when they're not in REM sleep on their back, but when they're in REM sleep on their back, that's not going to be enough. So sometimes it may seem odd that we're like, well, they need CPAP even though they've got mild disease. But it's because of the nature of their disease. Let's see. Next, oral appliance side effects. Patients can complain of jaw pain, temporal mandibular joint issues, malocclusion. So for 8 hours, if you've got something that's moving your jaw around, it can move your teeth around, and it can also make you feel like, my teeth aren't quite coming together quite right. In my opinion, oral appliances, we don't do them, so we refer patients for them. And I think they're an important part of therapy, but we don't do that, because if patients start having dental problems from these, you want these to be made and monitored by someone who knows what they're doing, because you can invite a whole different host of problems with tooth migration. And then the other thing is that if patients get referred for an oral appliance, they should be studied after treatment to make sure that you've actually done something to help their disease. Because for some patients, the obstruction is not always well addressed by the oral appliance. So you really want to make sure that you've gotten them this device. Is it actually helping? So they should undergo a home sleep test with the device in place to make sure that it's working. There are lots of surgeries that can be done to open up the airway. The uvulopalatopharyngeoplasty, or the UPPP, which is tonsillectomy, removal of the uvula, and alterations of the palate that open up the airway. A lot of sort of nasty sounding surgeries that can be done. These were very prevalent 10 years ago, less and less so more recently. It turns out that a lot of these surgeries are not as enduring as we had hoped. The other thing is we are really terrible at predicting who's going to be successfully treated with these. So it's really hard to look at a patient while they're awake and determine whether or not their airway is going to be effectively treated with a surgery. This maxillomandibular advancement is actually a surgery where we break the upper and lower, not me, a surgeon, breaks their upper and lower jaw, and it actually advances the entire bite forward to open up the posterior airway here. Sounds horrible. For patients that otherwise would be maybe forced to get tracheostomy, this is a great surgery and extremely, extremely effective. And then positional therapy. We talked about patients who sleep on their back and are worse. We have different devices they can wear that actually make it uncomfortable or difficult to sleep on their back, or maybe a body pillow or other things that help with that. There are all sorts of other technological devices that beep and buzz if patients turn onto their back and so forth. Types of positive airway pressure, I'm not going to dwell too much on this, but CPAP, we've talked about CPAP. What does that stand for? Continuous positive airway pressure. So that's just inflate the airway. It acts as a pneumatic stent to push the tissues out of the way to keep the airway open. A lot of patients think that it's blowing air into them. It's actually not. It's just inflating the airway. And I often take an exam glove and I blow into it and I squeeze it and the fingers pop up and I say, that's continuous positive airway pressure. Take my hand off and the glove falls limp. That's what it's doing. It's just opening up your airway. And then you can breathe with that airway open. BiPAP, on the other hand, bilevel, has a higher pressure when the patient inhales. It actually does augment their inhalation. They decide when they want the breath. They determine the size of the breath, but it augments their breath with a higher pressure when they inhale, and then when they exhale, they go back to a baseline, what you can think of as CPAP, to hold that airway open. We use that for people with various types of hypoventilation. Also for patients who don't tolerate CPAP. A lot of patients with CPAP, when they get inflated like that, they feel like they can't exhale. And if you get a chance to try the machines over there, you may sense that. BiPAP, by giving them a little bit more volume on the inhale, gives them a little bit easier time exhaling. So sometimes we put people with straight sleep apnea on BiPAP because it's more comfortable. And then there's various other devices. I'm not going to dwell on the complexities of these, but there are patients with who are on methadone, have central sleep apnea, who stop breathing. We have devices that will kick in and breathe for them when they have those central events that are very successful. You'll see these masks in just a little bit. And then CPAP titration options. So once your patient has a diagnosis, let's say assume they got the home sleep test, now they need to be started on CPAP. The way to figure out what pressure is going to hold their airway open is we can do an in-lab titration where we have them come spend the night. While they're sleeping, the technician is increasing the pressure in the mask from outside the room, watching those graphs that I showed you until their breathing is normal, and then we know that's the pressure that treats them. It's nice because we can make sure that when they're on their back, when they're in REM sleep, we're treating them and they're adequately treated. The auto-titrating device is a device that they take home. The device has a range of pressures that it can explore, and it has a proprietary algorithm by which it measures flow in the mask. So the patients wear the mask. If there's a period of time where there's no flow, the machine will say, oh, I wonder if you're having an event. It'll up the pressure a little bit to try to open up the airway a little bit. It'll monitor for a while. If flow is good, it'll stay there or even drop back down. If there are more events, it'll go back up. And in so doing, it'll go up and down in pressure all night long. And then we can look at a download from that device and say, okay, you needed such and such a pressure. If we talk about compliance reports, we may talk a little bit more about that. The advantages of the in-lab titration are that there's a technician present. Patients can try lots of different masks. A lot of times patients try one mask and they're like, that mask is kind of pinching a little bit here or it's leaking over there. And then the technician can try another one. Sometimes they go through 5, 6 masks in a night. If a patient goes home with a single mask, they might lie down 20 minutes later. They're like, this thing kind of sucks. I think I'll stop using it. They come back 30 days later. They've got 20 minutes of usage. And you're like, what happened? And they just didn't follow up. And again, for patients with transportation issues or other challenges in their lives, that can be difficult because it can be a big stumbling block to getting them treated. They need to come in and try a different mask and then try a different mask or whatever. So again, if I had my druthers, every patient would be in lab for all this stuff because I think it's the best. It costs money. We're trying to do a lot more of this out of the lab auto-titrating stuff, but there are a lot of stumbling blocks with that. And patients, you already ask them to put a mask on. I always tell patients it's the odd patient who comes into my office and says, oh boy, I want one of those. I want to sleep with one of those for the rest of my life. But as I tell patients, if you need it and it works for you, you're going to love this thing and you're going to not want to sleep without it. But it can be a big challenge getting patients there. And that's what we do. That's what we specialize in at our sleep lab, is making sure that your patients, when they come to us, are going to get treated, that we're going to have them successful and compliant on that device before we turn that patient back over to you for their ongoing care. That's more about the auto titrating, and we kind of covered this stuff. For auto titrating CPAP, again, it's helpful to have a reliable, competent patient that is accepting of CPAP. You know, someone you can trust that's going to work the problems with you, not the patient that gives up easily on a lot of stuff. Well educated. It's so important to educate these patients on the severity of their disease. In so many situations out in the community, they get told, you know, they just show up, you've got bad sleep apnea, here, go use this machine. And they don't understand, like, well, okay, what impact is this having on my life? How does this sleep apnea affect all these other things? How am I going to feel better? How do I deal with all the troubles along the way? What's the real severity of the disease? So many times we see patients who were treated somewhere else or got a test somewhere else, and we sit down with them and go over the results, and they say, oh my God, I had no idea I had sleep apnea that bad. Of course I'll try the CPAP now. So that really helps with the motivation. Physician requirements, timely follow-up of results. Patients need to be followed up for a lot of different reasons in a timely manner. Got a couple minutes left here, so I'm going to skip ahead here. Oh, that's the break. All right, well.
We're really good on time here today. Dr. Bowerfind is just like on it like Donkey Kong here. So we have some time if we want to just have a little mini Q&A session before we take a break. Let's take advantage of that. I just asked that before you ask a question, let me run over with his mic so I can get you, so our folks who are on the Skype connection can hear too.
So, I think you kind of went into this, but then I had the question again. If you do a home sleep study and that's only going to rule in that yes, you have it because we thought you did, then the next step is to come to a lab one anyway. It's like, why not just come in and do the lab and get the split in the first place?
So great question. So the issue there is, first of all, we can do the auto-titrating CPAP. So ideally, the least expensive way to assess and treat patients is to get the home sleep test followed by an auto-titrating device, okay? There are challenges with that, just as there are challenges with the in-lab assessment as well. It requires a lot of patient time, and again, it's more expensive to do the in-lab stuff. As I said, I think patients get a lot better attention and understanding and a lot of TLC in the sleep lab with all that stuff. So, yeah, that's great. But you saw the numbers at the beginning of this. 250,000 people in the Portland area. We don't want to bankrupt health systems either. So we have to be targeted in our approach to this. And that's why, you know, it takes in part the severity of the disease, in part your knowledge of that patient and how well are they going to be able to do all of this on their own, or is this somebody who really needs some hand holding? You know, they're really anxious about the CPAP, and you know, we get some sense of, boy, this patient is just not going to do well if I send them home with that device. We're spending the money to get all this diagnosis and getting the machine and so forth. And I think there's so much money wasted on getting patients tested and treated for a machine that ends up sitting in the closet or being sold at a garage sale, you know, months later. And that's why, you know, at the beginning of this, I said we spend a lot of time and angst about the upfront cost of assessment and treatment. We got to remember that if we can do it right and get these patients treated long term, that's where we're going to save lives, improve quality of life, and save money. But your point is well taken. Yeah, I mean, there are patients who get the HST and then they need the in-lab because it was negative. Well, we didn't save money there. And then we do the, you know, and then they have an in-lab study where we can't split them, but then they ultimately fail the auto-titrating, so they got to come in for an in-lab titration. now we're really not saving money. But we're getting through the problem with that patient and getting him treated ultimately. We're hoping that, you know, the next patient that walks through the door, we can get them treated by the other pathway. So the optimal pathway for all of us would be the home sleep test followed by the auto-titrating device.
How quickly do you start to see outcome changes with initiation of therapy? Because, you know, I'm in the home care practice, and so one of the challenges for us is to try to think about prognostically what is the value of this, knowing that, you know, we're talking about maybe stretcher transport to get to your office visit and the sleep study. So just wondering about how to think about this in terms of prognosis.
Yeah, a lot of that depends on the severity of disease. So most of these health benefits correlate with the severity of disease. So for people with really mild disease, I can't look them in the eye and say, you know, we're going to improve your blood pressure, we're going to add years to your life. People with really severe disease, yeah, there are real health benefits from that. And then it's a gradient as you go up in the severity of disease. The improvements in their immediate quality of life, I mean, we have patients who get a split night study and they're wearing CPAP during the second half of the night. That pressure isn't even at the optimal pressure until the last 45 minutes of the study. They wake up in the morning and they're like, "Oh my God, I haven't felt this good since I was 14." And that was like 45 minutes of optimal treatment. So the improvements on their quality of life can be immediate, can be literally night and the next day. And that's really exciting. And this is why this is a really great disease to treat, because, again, you're asking patients to undertake a pretty intensive intervention, but they come back and they frickin' love you if you have given them their life back and their sleep back. So, you know, the long-term health benefits, it varies depending on the severity of disease and what their comorbid conditions are. But we have people who come back and it literally adds IQ points to them. We see people who were thinking that they had dementia who come back and, you know, are in tears saying, "Oh my God, you know, I thought I was losing it." So it varies patient to patient, and I try not to make too many promises up front, but I say, you know, we'll see what happens, but I'm really hopeful that we're going to see a lot of benefit here. And, you know, I know that it's a struggle for those patients in the home environment, but we can work on that. I mean, we can get that done. We do the home sleep test with those folks. We do the auto-titrating for those folks. And maybe it's not optimal in that condition, but you can still get the job done. You know, there's what's best on paper, and then there's real life. And we all have to function in that latter environment.
Hi. I have two questions. First of all, how long do you leave patients on the auto-titrating? Will you leave them on that indefinitely, or do you try to switch them over to a separate?
Yeah, good question. So there are a lot of patients who we leave on auto-titrating indefinitely. I can talk a little bit more about that. Usually the initial thing is ideally like 7 to 10 days of an initial look to see how they're doing. Oftentimes that extends out to about the 30-day time frame, because I didn't touch on this yet, but compliance is something that you have to look at on the other end of this. And compliance means that patients are wearing their device for 70% of nights, at least 4 hours per night. Why 4 hours? It was shown in a lot of studies that at least 4 hours is what you have to wear in order to begin to get clinical benefit. Obviously, we want patients wearing it 8 hours every night. So you have to see your patients back 30 to 90 days after you initiate treatment, and you get a download from the machine, and we have some information on this in the subsequent portion. You have to get a download from the machine to assess that compliance. You can also use that with the auto-titrating CPAP to assess compliance, but also to take a look at the auto-titrating CPAP and see what their requirements are. Briefly, there are patients who benefit from auto-titrating for a number of other reasons. Back to the question about positional therapy. Patients, again, we see patients who have no sleep apnea when they're on their side, horrible sleep apnea when they're on their back. Those patients don't need much CPAP on their side, but they need a lot on their back. So there are some patients who don't tolerate being at that really high pressure that it takes to treat their sleep apnea when they're on their back for the whole night. So we can put those patients on auto, where when they turn on their side, the pressure comes down, and then they turn on their back, and the pressure goes up in response to the respiratory events. Also, patients who complain about like their stomach filling up with gas, we call that aerophagia from the night from the high pressures. We put patients on auto-titrating so that they are at the lowest mean pressure over the course of the night. The machine is going up when it needs to and going down when it doesn't need to. And you might say, well, why the heck then do you not put everybody on that? And the answer is that for patients, some patients, those changes in pressure are very disruptive. For other patients, those changes in pressure don't happen fast enough. So, and the other thing is that auto-titrating CPAP is reactive. And by that I mean patients have to experience events for the machine to titrate up. So all night long, they're having to have events in order for the patient or for the machine to titrate that pressure up. If you just treat them with a single pressure, you can eliminate all those events that are happening at the lower pressures. So a lengthy answer to your question, I thought.
Yeah, that's a good answer. Thank you. I know that we're probably almost out of time, but I think this comes up often. I often see patients who are on a CPAP, they're trying to wear it, and they're still having symptoms, and I'll uncover like a big weight change, like a big weight gain since the last sleep study. Is there a specific amount of weight gain that you think warrants a new sleep study, or is it just symptomatic?
Yeah, good question. So in general, ballpark is a 10% change in weight. And that could be either way, because patients who are on a high pressure who lose 10%, maybe they can tolerate now lower pressure. And maybe we put that patient on, switch their device over. And these devices actually, you can change the modes on them. So they can do these different things. So patients, we might put them on an auto-adjusting at that point to see, do they need a little bit higher pressure? Do they need a little bit lower pressure with the weight change? The other thing, you mentioned weight gain since their last sleep study. One thing that you have to warn some patients about is that patients with horrendous bad sleep apnea, when they are sleeping at night, they'll tell you, I wake up with sweats and I feel like I'm running a marathon and I wake up short of breath, and they kind of are running a marathon. And then you treat them, and some of these patients will come back and their chief complaint is, I'm sore. And part of the soreness is they're not moving at night. They're sleeping like a dead person at that point because they're not having to struggle to breathe. Also, they're not burning 900 calories at night while they're sleeping. So they continue with their same intake, and they're no longer exercising all night long, so to speak, and they end up gaining weight. It's something that we try to warn some patients about if we anticipate that. But there can be an increased weight gain, and patients are like, why am I gaining weight? And it's because you're not burning your caramel macchiatos as effectively at night anymore. So yeah, 10% change in weight is kind of the ballpark.
I have a question. I'm a family medicine physician, and I work at a community health center, so the majority of my patients are on Medicaid. We have a big proportion of our patients who probably should just be getting into you right away. But my question is sort of about our prepping of them, because a large subset of them have a significant history of PTSD, trauma, et cetera. And some of them take a year to convince to actually even consider having a sleep study. So I guess my question is, for us in primary care, as we're talking to our patients, what can we tell them about the support they'll get when they get into your office? Should they bring somebody with them for that first visit, knowing that they are traumatized already by a lot of elements of the healthcare system? How do you manage that kind of patient population? I have someone I took a year to get in to see you, and she's finally doing really better, but it's way too late. I mean, she's really ill. So we have a lot of those patients, and some of them just will never go.
Yeah. So obviously incredibly challenging population with PTSD or other anxiety issues, and then you ask them to put these masks on potentially. We have an incredible staff in our sleep lab. We are blessed to have folks who have been with us for a long period of time that are incredibly empathetic and spend a lot of time with patients. So, and a lot of that is introducing them to what do these things look like, and we even do sleep tech visits before sleep studies. So if I feel like somebody's going to have a challenge with that, I will say, you know what, why don't you come in during the day? We're just going to have you lay down on the bed, put a mask on you, no pressure. We don't even put the straps on. We just have them hold the mask to their face for a little bit. After a while, we might turn the machine on, have them hold it to their face with the pressure on. After a while, if they're breathing comfortably with that, you know what, why don't we try putting the straps on? Let's turn on the TV. We'll be back in 5 minutes, see how you're doing, in terms of introducing masks like that. We definitely try to, show them the sleep lab, show them that it's not Frankenstein's lab. Talk to them a lot about the benefits of how this may help with their anxiety and the benefits of a good night's sleep, and the fact that with PTSD, they've got those surges of adrenaline and that fight or flight, and we're going to actually give your body the rest that it's been seeking for so long. You have a lot of issues that are going on during the day. We're going to hopefully alleviate some of that at night, so at least you're getting that break, because right now, you're not even getting that break when you're sleeping. So a lot of this is just sort of talking through that aspect of things about the benefits of this. And some of it may be that they decide on that first visit that they don't want to do the sleep study quite yet. I think it's great if they bring someone with them who can continue to talk to them about that. And then we set up, a follow-up appointment either way to make sure that they come back and talk about this stuff again. I think, so much of that is on the education side of that. So, again, we are blessed to have an hour to spend with these folks, and we try to suss out some of that stuff and try to be targeted with our approach in that. If there are things we can do in terms of other medications, we really in our sleep lab try to avoid the prescription of medications and hypnotics as much as possible. It is very rare that we prescribe any of that stuff. But sometimes you need to help patients along the way with some of that if it's appropriate. So, there's no real right one way to treat those folks, but I can guarantee you that your patients will get the education and the time and attention both from the initial consult but also in the sleep lab. We are definitely about making sure that those folks are compliant and not just about running them through a mill and here's your machine, good luck with that. And I don't really care whether you succeed or not because we've done our front end stuff.
Incredibly illuminating. Oh, we got more.
Is there anything you'd like us to put into the referral for those particular patients so that you're aware that they might have extra issues?
Yes. So if you think that patient we can accommodate an hour and 20-minute visit for some patients, and for patients with insomnia and PTSD sort of stuff. If we know that coming in, we'll actually allot a little bit longer time. So that can be helpful. Knowing if they are challenging patients, we also may triage them differently to different providers. So we have some non-physician providers that help us with the treatment and management of the more straightforward sleep apnea patients. And then the patients who have more comorbid or complex situations may see one of our other providers. So that stuff is helpful. Again, Epworth, stop bang, symptoms, so snoring and daytime sleepiness. If you can at least tell us they're having a symptom and a life effect from that, and if you can identify any of the additional comorbidities, all of that helps us begin to triage those patients. So much of the time what we actually get is a note that has diabetes, hypertension, all these other things, and then in the assessment it says sleep study. And then we're like, okay, great. Can you tell us anything about symptoms? We really, to be responsible about our triaging and so forth, we need to have some documentation that, you know, you think this patient has a sleep problem, so you may say excessive daytime sleepiness, then please give us something that makes you think that it's also attributable to sleep apnea, like snoring, witnessed apneas. Those are great if you can give that as well, because otherwise, you know, is it insomnia? Does this, you know, that would be a different thing if they're just having, you know, daytime issues, but we don't think they have sleep apnea. So any of that is helpful.
Folks, we're going to jump in for our first break of the morning. But before we do, please give a huge, appreciative round of applause to Dr. Bowerfind. Incredibly illuminating. Thank you.